Hello, and thank you for joining this webinar entitled Language Matters: Communication Strategies to Help Promote Alcohol-Free Pregnancies. My name is Sandra Gonzalez, and I'm an assistant professor in the Department of Family and Community Medicine at Baylor College of Medicine in Houston, Texas. I'm also a licensed clinical social worker. This training is sponsored by the Medical Assistant Fetal Alcohol Spectrum Disorders Practice Improvement Center, or FASD MAPIC, which is based at the University of Nevada, Reno's Center for the Application of Substance Abuse Technologies, which is a part of UNR School of Community Health Sciences. The MAPIC has an ongoing partnership with the American Association of Medical Assistants, and the goal of this partnership is to prepare medical assistants to conduct a range of FASD prevention activities that may fit with their specific scope of practice within their home healthcare teams. This may include screening, serving as a liaison between providers and patients, providing feedback and education, and building motivation amongst patients and health team members in order to reduce the risk for alcohol-exposed pregnancies. The AAMA-MAPIC partnership is supported by grant funding from the Centers for Disease Control and Prevention. This training is divided into 3 sections. Section 1 provides an overview of FASDs, including what they are, the cause and prevalence in the United States, the characteristics of an individual who has been prenatally exposed to alcohol, prevention of FASDs, screening techniques to determine whether a patient is at risk for an alcohol-exposed pregnancy, and how a medical assistant can talk to patients about their alcohol use. Section 2 discusses stigma and provides guidance for discussing alcohol use without contributing to the stigma associated with FASDs and alcohol-exposed pregnancy. Section 3 focuses on the importance of choosing the right words and using helpful communication strategies when talking about prenatal exposure to alcohol so that patients feel comfortable discussing their drinking with their healthcare providers. This training is primarily aimed at building your knowledge so that you can talk to patients, colleagues, students, and others with accuracy about the cause of FASDs and the risk of drinking alcohol during pregnancy. Throughout the presentation, you will be engaged in thinking about the role you can play as a medical assistant in reducing AEPs and preventing FASDs. Please be aware that you have boundaries related to the professional standards governing the work you do as a medical assistant. It is your responsibility to be aware of your state or employer scope of practice guidelines. I would like to draw your attention to the following note on gender-specific language. The Medical Assistants FASD Practice Improvement Collaborative, or MAPIC, notes that not all people who give birth to children identify as mothers, and not all people with the ability to become pregnant identify as women. However, many current research studies use gender-specific words such as women and mothers when discussing childbirth and pregnancy. The research cited in this training will reproduce the original terms used in the source study. In general, these terms refer to people who were assigned as female at birth. All right, let's go ahead and get started with Section 1, which provides an overview of FASDs, including the lifelong effects, identifying characteristics, screening, and prevention. The key concepts for this section are: what are FASDs? What are the identifying characteristics? How common are they? And what are the benefits of early intervention? The 3 key elements of FASDs are: 1, the term fetal alcohol spectrum disorders, or FASDs, has emerged to address the need to describe the spectrum of disorders related to prenatal alcohol exposure. Disorders range from mild impairments or behavioral issues to profound disabilities and even death. 2. FASDs are caused by prenatal alcohol exposure. And 3, there is no cure for FASDs. These effects are lifelong, but their impact on a person's life can be lessened through early recognition and diagnosis, followed by appropriate support and interventions. Alcohol use during pregnancy is a problem because it can affect the development of the baby. Alcohol is a teratogen. Teratogens are substances that are known to cause malformation after prenatal exposure. Alcohol can go anywhere water can go inside the human body, and it freely dissolves inside most body cells, which are 98% water. The nearly complete distribution of alcohol into most body cells helps us understand why the effects on the baby are so widespread. When alcohol dissolves into the cells that make up the central nervous system, it affects the baby's brain. Dissolving into the cells that make up body structures can result in facial abnormalities. The cells of the baby's liver, kidney, and heart are exposed to alcohol. Although the placenta acts as a barrier for many toxins that might harm the developing baby, the widespread distribution of alcohol into cells affects the placenta's ability to block alcohol from the maternal blood. Consequently, alcohol is easily passed from the mother to the baby and distributed throughout the tissues and cells of the baby. Because the developing baby's liver and enzymes responsible for ethanol metabolism are not fully developed, the baby's ability to metabolize alcohol is limited and results in high alcohol levels. Thus, alcohol's water-soluble quality, ability to cross the placental barrier, and the baby's inability to metabolize alcohol helps us understand why the effects on the fetus are so widespread. First, let's get oriented to this slide. The top shows weeks of development. After week 8, the timeline is condensed. Interpret the fetal development chart on the screen as follows. The purple portion of the bars represents the most sensitive periods of development. During these periods, the effects of alcohol consumption would be the most harmful and result in major structural abnormalities in the fetus. The pink portion of the bars represents periods of development during which physiological defects and minor structural abnormalities could occur. Central nervous system, or CNS, effects refer specifically to the brain. And the chart refers to the 38 weeks of pregnancy rather than 40 weeks. So week 3 on the chart is week 5, counting from the last menstrual cycle. It is important to note that there is no safe time and no known amount of alcohol that is safe to drink during pregnancy. There is also no type of alcohol that is safer than others. Beer, wine, wine coolers, and hard liquor all have the same effect on fetal development. The timing of the exposure of alcohol influences how it affects the fetus. Significant exposures in the first couple of weeks post-conception can cause pregnancy loss. Exposures later in the first trimester are associated with structural birth defects and the abnormal facial features that are characteristic of FAS, or fetal alcohol syndrome. Second and third trimester exposures can be associated with pregnancy loss, brain anomalies, and impaired growth. The pattern of drinking also influences how the fetus is affected. The overall risk of a problem caused by alcohol increases with the amount of the exposure. In other words, increasing dosage is associated with greater effects. Likewise, the longer the time of the exposure or the duration, the greater the effects. In general, binge exposures, which are characterized as heavy drinking on one occasion, may cause more problems than chronic exposures or drinking over many days. FASD is an umbrella term used to describe the range of effects that can be caused by exposure to alcohol in utero. FASD is not a clinical diagnosis, but rather a descriptive term that encompasses all of the conditions attributed to prenatal alcohol exposure. In other words, an individual does not have FASD, but an FASD. Diagnoses along the spectrum include fetal alcohol syndrome, FAS, which is the most widely known diagnosis, alcohol-related birth defects, ARBD, partial fetal alcohol syndrome, PFAS, alcohol-related neurodevelopmental disorder, ARND, and neurobehavioral disorder associated with prenatal alcohol exposure, NDPAE. Specific criteria must be met for a diagnosis of FAS, including specific facial features, growth delays, developmental delays, learning disabilities, and/or social or behavioral problems. Many individuals exposed to alcohol in utero will not have the facial features or growth problems required for a diagnosis of FAS, and may be diagnosed with another condition on the spectrum. Unlike FAS, the characteristics associated with other disorders along the spectrum may be more subtle and may not be recognized until the child is older or even into adulthood. There are a number of things that individuals who care for or work with children may notice that alerts them to the possibility the child has an FASD. Some of those things are developmental or behavioral concerns, specific facial features associated with prenatal alcohol exposure, growth deficiency at or below the 10th percentile for head circumference, height, or weight at any time, including prenatally, a history of confirmed or suspected prenatal exposure to alcohol, and this could be an admission from the parent who has carried the child regarding alcohol use during pregnancy, and this is helpful when making a diagnosis, but not always needed or available, for example, in the case of adoption. Some of the FASD diagnoses do require documentation, some do not. And lastly, self-reported or family concern about possible FASD. There are three characteristics associated with prenatal alcohol exposure: specific facial features, growth deficiency, and central nervous system problems. As stated earlier, specific criteria must be met for a diagnosis of FAS. However, the characteristics associated with the other disorders along the spectrum may be more subtle and may not be recognized until the child is older, again, or even into their adulthood. I'm going to talk a little bit about the facial features associated with fetal alcohol syndrome. The specific facial features or facial dysmorphia that characterize fetal alcohol syndrome, or FAS, include the smooth philtrum, which is the smooth ridge between the nose and upper lip, the thin vermilion border, which is the thin upper lip, and the small palpebral fissures. That is the short distance between the inner and outer corners of the eyes, giving the eyes a wide-spaced appearance. Let's take a look at a comparison of a child without FAS and one diagnosed with FAS. See if you can see the facial features. Do you see the thin upper lip, the thin vermilion border? and the smooth ridge between the nose and the upper lip, the smooth philtrum. Growth deficiency and central nervous system effects are also characteristic of FAS. In terms of growth deficiency, prenatal alcohol exposure can affect a child's growth. The general guideline for documenting growth deficiency is when prenatal or postnatal height, weight, or both are below the 10th percentile for a specific age at any time. Growth deficiencies can also occur during pregnancy, referred to as small for gestational age. Growth deficiency is measured against norms for gestational or postnatal age, sex, race, or ethnicity. When considering the FAS diagnosis, environmental and genetic reasons for growth retardation should be considered. Some children with FAS will catch up in this area. For example, many adolescents gain weight on par with children who do not have FAS. Next, we'll talk about central nervous system problems. The central nervous system is made up of the brain and the spinal cord. 3 categories of central nervous system problems are associated with FAS, and they are structural, neurologic, and functional. Let's start with structural. Signs of structural differences are smaller than normal head size for the person's overall height and weight, again, at or below the 10th percentile, significant changes in the structure of the brain as seen on brain scans such as MRIs or CTs. Next, neurologic. Nervous system problems that cannot be linked to another cause. Some examples include poor coordination, poor muscle control, problems with sucking as a baby. And lastly, functional. The ability to function is well below what is expected for the person's age, schooling, or circumstance. Cognitive deficits, such as low IQ, or developmental delays, such as specific learning abilities, especially for math or other visual spatial deficits, and executive functioning deficits. It involves the thinking processes that help a person manage their life tasks. For example, organization and planning. Individuals who are affected by FAS may have difficulty with organization and planning. They may have difficulty following directions and may exhibit poor judgment. Research has demonstrated that there can be long-term consequences for children exposed to alcohol during pregnancy. Prenatal alcohol exposure is associated with a variety of potential alterations to the developing brain. These alterations might be expressed as changes in functions related to thinking, learning, and moving. No matter how severe or subtle they might be, the effects of alcohol might contribute to intellectual disability or movement disorders. Various problematic behaviors are also associated with problems caused by alcohol exposure to the developing brain. One of these effects is attention problems, such as attention deficit disorder, ADD, or attention deficit hyperactivity disorder, ADHD. A child with these problems might be described, and this is not a complete list, as having poor social skills, including lack of stranger fear, inappropriate choice of friends, and preference for younger friends. Individuals with an FASD have a higher incidence of co-occurring psychiatric, emotional, and behavioral problems. Children and adolescents with FASD have a 95% lifetime likelihood of experiencing mental health issues, including anxiety and mood disorders, particularly depression, ADHD, substance use, and addiction. The prevalence of FASDs in the United States is estimated to be as high as 2 to 5% of school-aged children, a rate similar to that of autism spectrum disorders. CDC studies have estimated FAS prevalence at 0.2 to 1.5 cases per 1,000 live births, while other studies using different methodologies have reported higher estimates of 6 to 9 cases per 1,000 children. Prenatal alcohol exposure appears to affect a significant proportion of children in the foster care system. One study found that FAS prevalence estimates could be 15 cases per 1,000 children. Another study found high rates of misdiagnosis or misdiagnosis of foster and adopted children with fetal alcohol spectrum disorders. The effects of prenatal alcohol exposure on memory, judgment, and other executive functioning may be a contributing factor to the evidence that more than 20% of individuals in the juvenile justice system have a condition related to prenatal alcohol exposure. FASDs have high economic and societal costs. Annual costs associated with drinking while pregnant in the United States are estimated at approximately $5.5 billion. This includes costs associated with drinking during pregnancy, such as hospitalization or decreased productivity, as well as increased costs for care and services of affected infants and children, such as special education for children with an FASD. The lifetime cost for an infant with FAS is estimated at approximately $2 million. Reported Medicaid costs incurred by children with FAS in 2011 were 9 times higher than costs for children without FAS. Individuals with FASDs require support throughout their lifetime. Many are at increased risk for mental health disorders, disrupted school and employment experiences, legal problems, challenges with living independently, and substance use disorders. Parents and family members of individuals with FASDs tend to experience increased levels of stress and will benefit from increased support. In addition, people with FASDs themselves are at an increased risk of having an alcohol-exposed pregnancy. Early identification before 6 years of age, when possible, helps reduce the risk of later life problems, such as problems in school, things like dropping out, repeating grades, mental health problems, depression, attention difficulty, inappropriate and/or risky sex behaviors, alcohol and drug use problems, and legal problems, including jail time. Early diagnosis works by helping families affected by FASDs to get the support and services they need, which can include counseling, medical specialty care, and peer and community programs. Identifying an individual with an FASD can also serve to identify maternal mental health and addiction concerns. This provides an opportunity for an intervention and may prevent subsequent alcohol-exposed pregnancies. It's important to note that the intention of this training is not to teach medical assistants to screen patients for an FASD. However, it is important for medical assistants to understand the concerns associated with prenatal alcohol exposure so that they can be a part of the interdisciplinary team that is engaged in FASD prevention and early identification. Now let's talk about screening and prevention. These questions serve as key concepts for the section. What is risky drinking? Why is early diagnosis important? And are FASDs preventable? To accurately assess whether or not a person is consuming alcohol at a risky level, there must be a shared understanding of what constitutes a standard drink. The National Institute on Alcohol Abuse and Alcoholism, or NIAAA, defines a standard drink as any drink that contains approximately 14 grams or 0.6 fluid ounces of pure alcohol. And that is the amount that's contained in one 12-ounce beer or wine cooler, one 8 to 9 ounce malt liquor, one 5-ounce glass of wine, and 1.5 ounces of 80 proof distilled spirits. These figures are estimates, since the actual amount of alcohol varies based on the brand and type of beverage, as well as the size of the beverage container. For example, 8 to 9 ounces of malt liquor is considered to be one standard drink based on the alcohol content of that drink. However, many malt liquors are sold in 40-ounce containers, which is the equivalent of 4.5 standard drinks. Likewise, a typical 25-ounce or 750 milliliter bottle of table wine holds 5 standard drinks. Thus, it is essential that patients be asked about the number of drinks they consume and the size of the container they used. This is actually something that my patients often have questions about. It is important to remember that today's alcoholic beverages aren't all created equal and aren't the same as they have been in the past. For example, many craft beers routinely contain 50 to 100% more alcohol by volume. I was recently shocked to learn that there are beers in the US that have alcohol content upwards of 20 to 30%. Other culprits to keep an eye on are mixed drinks served in larger containers and those comprised of several types of liquors, such as Long Island iced teas. It is important when caring for people who may become pregnant to assess their alcohol consumption, as it is a key time to prevent alcohol-exposed pregnancy. People who have an understanding of risky drinking limits are more likely to drink below risk levels. For non-pregnant women, excessive alcohol use means more than 3 drinks on any one occasion or more than 7 drinks in a week. Drinking over these amounts places the individual at risk for problems related to their drinking. Guidelines on alcohol use during pregnancy are clear. No amount of alcohol is considered safe during any trimester of pregnancy. And this statement is endorsed by the 2005 U.S. Surgeon General's Advisory, the American College of Obstetricians and Gynecologists, the American Academy of Pediatricians, and the Centers for Disease Control and Prevention. All of the agencies that I mentioned have endorsed the advisory that states no amount of alcohol is considered safe during any trimester of pregnancy. And as a note, this includes all types of alcohol. The advisory is based on the scientific finding that alcohol consumption during pregnancy increases the risk of alcohol-related birth defects, which include growth deficiencies, facial abnormalities, central nervous system impairment, behavioral disorders, and impaired intellectual functioning. There are 2 primary ways to reduce alcohol-exposed pregnancies. 1, reduce high-risk drinking in people who may become pregnant, including abstinence. And 2, prevent pregnancy, for example, by using contraception effectively. The optimal outcome would be for patients to do both. In a study on the choices intervention, which we will discuss later, most participants who were at risk of pregnancy did in fact choose to reduce high-risk drinking and use effective contraception. Addressing risky drinking requires knowing which patients are consuming alcohol at risky levels. There are many readily available research-based screening tools that healthcare providers can use to assess drinking levels. Following screening, those who are drinking at risky levels As a reminder, that's more than 3 drinks on any one occasion, or more than 7 drinks per week, or any alcohol consumption for those who are pregnant or trying to get pregnant, should receive a brief intervention to help them understand the risk associated with their drinking levels and take steps to reduce that risk. SBI stands for Screening and Brief Intervention. Alcohol screening and brief intervention has been shown to be an effective, low-cost option to address risky drinking and alcohol-related harms, including preventing alcohol-exposed pregnancies. The concept of SBI is really simple. It uses a public health approach to universal screening for excessive alcohol use. The public health approach of universal screening means that everyone gets screened. Screening can immediately rule out problem users and easily identify those who are at risk. It is important to screen all people who can become pregnant because they do not always know when they became pregnant, exactly when they became pregnant. When screening, it is important to know if the person understands what constitutes a standard drink, as this may impact their responses to your screening questions. It is important to help people feel comfortable talking about their alcohol use. And it's important for us not to make assumptions about alcohol use based on looks or socioeconomic status. As mentioned earlier, the first step in alcohol SBI is pre-screening. This can be done by asking a single question. The single question screen can identify patients who may need more in-depth screening using a longer validated alcohol screen, such as the audit, the CRAFT, which is validated for adolescents, the TACE, which can be used for pregnant women, or the TWEAK. These tools can help detect if a patient is drinking too much, has experienced alcohol-related problems in the past, and has a reliance on alcohol that needs to be addressed. Screening tools allow for the standardization and tracking of drinking patterns among patients, and they can often be implemented in just minutes. Any member of the healthcare team can do the screening, and the healthcare team should agree on protocols for follow-up assessment, interventions, and referrals for anyone who screens positive for risky alcohol consumption. Questions presented as routine and asked in a non-judgmental manner typically produce the most reliable and valid information. For example, asking, "How much alcohol did you consume while pregnant?" rather than, "You didn't drink while pregnant, did you?" Questions that require yes/no answers, for example, "Do you drink alcohol?" should be avoided since they may limit or end the conversation. There are more in-depth methods of conducting a brief intervention that involve motivating the patient to identify change mechanisms and create plans to lower drinking levels. This type of brief intervention can easily be administered by a medical assistant or other professional, but it does require some training and practice. However, there are also very simple ways that you can support brief intervention for a patient who is drinking before or during pregnancy. For example, advising a patient who drinks moderately and is pregnant, or who is contemplating pregnancy, to abstain from alcohol in order to prevent an FASD. As I mentioned earlier, another intervention designed to prevent alcohol-exposed pregnancy is Choices. Choices is an evidence-based intervention that relies on several counseling approaches, including motivational interviewing and cognitive behavioral therapy. And the CDC's website is a great resource for finding information on how you can implement Choices. On the slide here, you have the Enhancing the Role of Medical Assistants, a toolkit to increase the capacity of primary care practices to reduce risky alcohol use and prevent alcohol-exposed pregnancy. And this resource was developed specifically for medical assistants and provides resources and information that can help them implement alcohol screening and brief intervention in their work setting. The toolkit, it can be downloaded from www.fasd.org/products/. Once again, I want to remind you all of the most critical message, and one that is misunderstood by many healthcare providers and patients, and that is that there is no known safe amount, no safe time, and no safe type of alcohol to consume during pregnancy. Thus, all members of the healthcare team are urged to advise women not to drink at all if there is any chance they could be pregnant, or if they are trying to get pregnant. Okay, before we move into section 2, let's review those key concepts for section 1. What are FASDs? FASD is an umbrella term used to describe a continuum of disorders ranging from mild intellectual and behavioral issues to extreme issues that may lead to profound disabilities or premature death. FASDs are caused solely by prenatal alcohol exposure and are not hereditary. And FASDs last a lifetime, but there are benefits from early diagnosis, support, and services. What is the guidance on alcohol use during pregnancy? People who are pregnant or trying to become pregnant should not drink any alcohol. No amount of alcohol should be considered safe to drink during any trimester of pregnancy, and FASDs are completely preventable with no alcohol intake during pregnancy. What is alcohol SBI? Alcohol SBI is alcohol screening and brief intervention, and it involves using a valid screening tool to assess drinking levels and then providing a brief intervention for those who are drinking at risky levels. During pregnancy, any drinking is risky, and patients who are pregnant who are drinking should be advised on the risk of alcohol consumption during pregnancy and receive support in order to identify how to reduce or eliminate drinking. And lastly, who should be screened to prevent alcohol-exposed pregnancies? All patients, with particular focus on any person who may become pregnant. Okay, let's get started with section 2. This section will examine stigma and how it contributes to patients' hesitancy to discuss their alcohol use. We will start with a short exercise. If you are comfortable, please close your eyes. I'm going to read a scenario aloud to you. You are walking down a street in the business section of your community. You are alone, and it is about 9 p.m. There are tall trees lining the street and attractive shrubs at the curb. You feel comfortable and unafraid. Suddenly, you see someone walking toward you. Looking closely at the individual, you notice a lack of coordination, which, as the individual approaches, becomes a stumbling gait. Feeling less comfortable, you keep your eye on the approaching individual, noticing that the odor of alcohol and vomit hangs in the air. The individual is muttering quietly with slurred speech. Looking into the person's face, it is easy to see the glazed eyes and puffy skin. This individual is obviously drunk. As you were listening to the scenario, what was the gender of the person you envisioned? Would your reaction to the alcohol-impaired person change if it were a woman What would your reaction be if the alcohol impaired person was pregnant? For section 2, we have another set of questions that serve as key concepts. They are: what is stigma? How does stigma relate to alcohol use? And why is it a barrier to preventing and identifying FASDs and prenatal alcohol exposure? Stigma arises from patterns of behaving, thinking, and feeling about human differences, be it physical appearance, cultural or social identity, health condition, disability, age, or gender. These things become negatively shaped by harmful cultural or personal beliefs, attitudes, and stereotypes. Stigma is enacted through labeling, social exclusion, prejudice, differential treatment, and discrimination against the stigmatized individual or group. The impact of stigma in healthcare is well documented, and it's shown to be far-reaching, contributing to health disparities through its negative effect on individual health, and is a barrier to access and delivery of quality healthcare services. Can you think of some examples where labeling, social exclusion, or prejudice may have caused an individual or a group to be stigmatized? Stigma, stereotyping, and bias related to alcohol use by women, FASDs, and those affected by an FASD harms the individual and creates barriers that hinder FASD prevention and care. Alcohol use and alcohol use disorders in women are often viewed more unfavorably than those of men. Many societies hold negative attitudes or public stigma toward drinking among women, and especially when women are engaging in heavy drinking. Stigma associated with drinking during pregnancy is common, yet the reasons that people may drink while pregnant, including alcohol dependence, mixed health messages, disruptive social conditions, and more, are not widely recognized or understood. According to a 2012 FASD United, which is formerly NOFAS, the Circle of Hope birth mothers, they identified some of the reasons why women drank while pregnant, and they include: first, misinformation. I thought using alcohol was safe. My doctor never told me I should not be drinking. Being unaware. I didn't know I was pregnant. I stopped as soon as I found out. Addiction. I'm an alcoholic. I couldn't stop and was ashamed to look for treatment. And finally, fear and shame. I was afraid to look for help. I was afraid I would be arrested and I would lose my children. Stigma is often associated with a health condition, and alcohol use disorders and substance use disorders are among the most stigmatized of medical conditions. For women who are struggling with their alcohol use or have an alcohol use disorder, the self-stigma, embarrassment, and perception of being devalued or judged by their family, colleagues, healthcare professionals, all serve as barriers to accessing treatment and to achieving and sustaining recovery. One of the major reasons we must call attention to stigma is because it leads to missed opportunities. FASD has no social, cultural, or economic boundaries. People who consume alcohol while pregnant come from all walks of life. 1 in 10 women report alcohol use during pregnancy. While women with substance use disorders may be at a higher risk for having a child with an FASD, women who drink socially, especially in a binge pattern, and those who drink before they know they are pregnant. So, in other words, any woman who consumes alcohol and is or might be pregnant are also at risk of an alcohol-exposed pregnancy. Before we move on to the next slide, I would like to ask you all to guess which age groups you think might have the highest alcohol use during pregnancy. According to CDC data gathered from 2015 to 2017, the largest percentage, 17.2%, were women aged 35 to 44. When it comes to educational level, the highest percentage is among college graduates. Again, according to that CDC data gathered from 2015 to 2017 that showed approximately 16.3%. It is important to remember that if medical professionals assume certain populations are less likely to engage in risky drinking, the opportunities for screening, identification of risky use, and prevention of FASDs may be lost. Stigma is a barrier to diagnosing FASDs. According to FASD United, quote, stigma is a major reason that FASD is substantially underdiagnosed and helps explain why FASD remains a largely hidden disability. Stigma can inhibit concerned parents from asking for help. The attitudes and beliefs of healthcare professionals similarly can influence how they communicate and interact with women or people who may become pregnant and who use alcohol, as well as individuals and families affected by FASD. Assumptions and bias about who may or may not be at risk of having an alcohol-exposed pregnancy, or even general discomfort on the topic of drinking and the social norms surrounding drinking, may prevent physicians from asking women about their alcohol use. Healthcare professionals may hesitate to ask about alcohol consumption because they do not want to be perceived as judgmental or imply that the patient is bad. At the same time, patients who do struggle with alcohol may experience shame and low self-esteem, forms of self-stigma, that can hinder accurate self-disclosure about alcohol use, particularly during initial screening. Further, healthcare professionals may feel that they or their staff do not have the knowledge, skills, or self-efficacy to work with individuals who are identified as having a substance use issue. Finally, for children who might be candidates for evaluation or services, healthcare professionals may be hesitant to discuss, diagnose, or make a referral due to discomfort with or fear of FASD labeling or thinking a diagnosis does not help the child. According to FASD United, quote, some doctors have reported that they won't diagnose a child with an FASD, even when they believe that it is an accurate diagnosis. They say that it is less complicated to diagnose the symptoms of FASD, such as ADHD or bipolar disorder. They don't want to stigmatize the birth mother, her family, or her child. One of the easiest things you can do to address stigma in your practice is to be aware of and eliminate the use of stigmatizing language. Stigmatizing language conveys negative attitudes, disapproval, and/or blame, can create feelings of shame and exclusion for the patient, can influence how others in the practice perceive the patient. So let's look at a couple of examples. Defining FASD as the range of effects that occur when a developing baby is prenatally exposed to alcohol carries much less stigma than a definition like FASD is what happens when a mother drinks alcohol when she is pregnant. The term prenatal alcohol exposure carries less of a stigma than mother's alcohol use. If we look at the example on your slide here, the patient has a dirty UA. A less stigmatizing way to phrase this is the patient's test was positive for, etc. There are lots of reasons that a person might drink while they are pregnant, but it is not because they want to hurt their baby. People who drink alcohol when they are pregnant tend to fall into three categories. One, they have an alcohol use disorder and are unable to stop alcohol use on their own. Two, they are not aware that they are pregnant. And three, they lack knowledge about the risk of alcohol use to their baby. I would like to show you a quick video that addresses the importance of providing consistent messages to patients about alcohol use.
Well, I was not about to do anything unless my doctor said so. I mean, that is what kind of pregnant person I was. And I went in and specifically asked. A friend of mine said that I could drink wine when I'm pregnant, and red wine, specifically red wine. And he said that was perfectly fine, that I could have like a glass at night with my dinner. And as a matter of fact, it may help me to relax and to have circulation and stuff like that. So not only did I think it was okay, and that's kind of what I wanted to hear, but I also thought, that it was possibly helping. Even when I asked, is it okay to drink wine when you're pregnant? He didn't ask me if I had a drinking problem or how many drinks I had a day, or, if I binge drank or if I'd ever blacked out when I drank. There wasn't really any dialogue.
Now, before we finish the session, let's go ahead and review section 2. First, what is stigma? Stigma is a powerful, complex, social and cognitive process that leads to the discrediting, devaluing, or excluding of a person or group of people based on a real or perceived difference. Stigma arises from patterns of behaving, thinking, and feeling about human differences, be it physical appearance, cultural or social identity, health condition, disability, age, or gender, that become negatively shaped by harmful cultural or personal beliefs, attitudes, and stereotypes. Stigma is enacted through labeling, social exclusion, prejudice, differential treatment, and discrimination against the stigmatized individual or group. The impact of stigma in healthcare is well documented, and it's shown to be far-reaching, contributing to health disparities through its negative effect on individual health status, and serves as a barrier to access and delivery of quality healthcare services. How does stigma relate to alcohol use? Alcohol use and alcohol use disorders by women is often viewed more unfavorably than that of men. Stigma associated with drinking during pregnancy is common. Stigma is often associated with a health condition, and alcohol use disorders and substance use disorders are among the most stigmatized of medical conditions. Why is stigma a barrier to preventing and identifying FASDs and prenatal alcohol exposure? Stigma can prevent concerned parents from asking for help. Providers are uncomfortable talking about alcohol use with patients. Negative attitudes about drinking can limit a medical professional's access to necessary training and skills. Providers may fear that labeling a patient as being affected by maternal alcohol use it could affect the patient, and thus they avoid the diagnosis. Medical assistants can avoid reinforcing stigma by remembering that words matter. Avoid using language that is blaming or shaming. Okay, we are now going to go ahead and move into section 3. And this section will draw attention to how we talk about alcohol in pregnancy and provide some guidance for discussing alcohol use without contributing to the stigma around FASDs and alcohol-exposed pregnancy. As in the previous sections, these are the questions that will serve as key concepts for section 3, which is titled Effective Communication. They are: what are some common communication roadblocks? How does communication affect change? And how can medical assistants communicate more effectively? Let's start with person-first language. Person-first language puts the emphasis on the person rather than on the person's status or disability. It puts the person first by using phrases such as a person who, a person with, or a person who has. Using this kind of language recognizes individuality and reduces stigma by avoiding equating people with their status or disability. In this slide, you can see some good examples of ways to use person-first language, such as saying a child who has an FASD versus an FASD kid, people with disabilities versus the disabled, and a person with an alcohol use disorder versus an alcoholic. If you remember from section 1, we must also be aware of and responsive to matters related to gender identity in order to provide the best care for all of our patients. Patients may identify as a man or a trans man or as non-binary or genderqueer and have reproductive organs that make them capable of being or becoming pregnant. Using the patient's preferred name, pronouns, and terms is a sign of respect and can help build rapport and make the patient comfortable. When in doubt, choose gender-neutral words. Use the pronoun they, partner or spouse instead of husband or wife, and parent instead of mother or father. Alcohol screening and brief intervention is still indicated, especially if they might be or become pregnant. As you may have discovered, there are excellent resources throughout the presentation that can be useful to you. There are additional guidelines on working with LGBT patients located at the National LGBT Health Education Center at lgbthealtheducation.org. One key to avoiding stigmatizing language is to be aware of how our personal values compare to our professional values. Let me ask you, How might your personal values influence how you interact with patients? Next, we'll take a look at some statements and see if you can consider ways to make them less stigmatizing. In this first example, we can change when a pregnant person drinks alcohol, so does their baby, to a developing baby's alcohol exposure can reach the same level as that of the parent who is carrying them during pregnancy. I can tell you from personal experience that we have come a long way in the past decade when it comes to changing our practice related to working with individuals at risk for an alcohol-exposed pregnancy. I remember when I first started working in this area and how common it was to see flyers or other educational material that read, "When mommy drinks, baby drinks." In fact, there was a popular infographic that showed a pregnant person's uterus and fetus seemingly swimming in alcohol within. Even then, it made me wonder how it might have affected a pregnant woman who was struggling with substance use. Here's our next statement. First, think about why this phrase is harmful and how we might rephrase it to decrease stigmatizing use of language. Some possible responses could be, many people are not aware of the harmful effects of alcohol during pregnancy. Another might be, many people are misinformed about the safety of drinking alcohol during pregnancy. And yet, another way to rephrase this statement would be, any person who consumes alcohol during pregnancy is at risk of an alcohol-exposed pregnancy. Here is our next phrase. Let's think about how we might reformulate it. The phrase is, alcoholics have babies with deformities and brain damage. What are some alternative ways that we might say this in order to decrease stigmatizing use of language? A couple of things come to mind for me. One, prenatal exposure to alcohol can cause a range of lifelong physical, behavioral, and intellectual disabilities. And two, a developing baby exposed to alcohol before birth is at risk for physical and cognitive disabilities. All right, let's do one more. Think about how you might rephrase this statement. Shame on you for drinking while pregnant. What about, thank you for sharing your experiences? Or sending a prevention message. The earlier you stop drinking, the better for your baby. If you need help stopping, let's talk about some resources. We have one more. Let's think about how we might reformulate this phrase. FASDs are caused by pregnant people who drink alcohol. Once again, I want you to think about a way that you might turn this into a prevention message. Something like FASDs are prevented by not drinking alcohol at any time during pregnancy. Or FASDs can occur when a developing baby is exposed to alcohol before birth. As we have been discussing, it is very important to create a clinical environment that is conducive to conversations about alcohol consumption. Being thoughtful about the words we use reduces resistance to talking about personal alcohol use. When it comes to effective communication, one of our most powerful tools can be avoiding strategies that are known to damage rapport or inhibit the likelihood of behavioral change. In our attempts to help our patients and reduce pain and suffering, we sometimes engage in practices that, while tempting, are counterproductive to our ultimate goal. Some of these strategies are unsolicited advice, persuasion, confrontation, getting ahead of patients, and one-way information. Extensive process research supports the ineffectiveness of these strategies in promoting behavioral change. In fact, in many cases, using these strategies actually encourages patients to defend their unhealthy behavior. It can diminish the trust in the healthcare team and negatively impacts the likelihood of change. Let's talk about ways in which each of these strategies may hinder effective communication. First, unsolicited advice. While in many cases we might be right, and patients would likely be better off if they heeded our advice, unfortunately, giving unsolicited advice can communicate to patients that they aren't capable of generating their own solutions. It can create passivity, or it can lead to patients arguing with us about why they can't or don't need to change. Next, persuasion. Persuasion is trying to convince another person to change their thoughts or behaviors. This can involve the use of logical arguments or self-disclosure about personal experiences with related issues. For example, I've worked with parents of children with an FASD, and believe me, the guilt they feel about their choices is not something you want to experience. Similar to unsolicited advice, persuasion can often lead patients to shut down and disengage or to resist change efforts. Confrontation is next. Confrontation occurs when healthcare professionals clearly and directly disapprove of a patient's thoughts or behaviors and communicate it via shaming, ridiculing, labeling, blaming, or arguing. For example, think of your baby, for crying out loud. Confrontation has a clear tone of judgment and disapproval. Confrontation may alienate a patient and may even damage the rapport beyond repair. Next, getting ahead of our patients. This is a subtler roadblock and is also one that is very common. Getting ahead of patients is responding in a way that is not appropriate to the patient's readiness level and fails to recognize ambivalence in patients. When thinking about making health changes, including reducing risk for alcohol-exposed pregnancy, patients are going to be at different readiness levels. In some circumstances, patients may not even be willing to discuss these issues or be honest about their risk behavior. And that's because they haven't developed a trusting relationship with you as a healthcare provider. In these circumstances, investing energy in the relationship by listening and engaging in other superhighways to communication that you will learn about later in this training is likely a better use of your time and energy then continuing to press on an issue that the patient is not ready to discuss. Even when patients are ready to discuss an issue, however, they might often be ambivalent about whether or not they want to change their behavior. Ambivalence is feeling two ways about something, and it is quite common. So, while on the one hand, a patient may want a healthy baby, on the other hand, it's hard for them to imagine how a drink here or there might hurt. When a patient is ambivalent about change, trying to plan with them about how change will occur is getting ahead of them and can cause them to disengage. When patients are ambivalent, we should avoid planning. Let's look at the example. Patient: I read that a glass of wine now and then is actually a good thing during pregnancy. In this case, the medical assistant gets ahead of the patient by responding, "What do you think might be the first step towards quitting?" Lastly, one-way information, which is defined as providing more information than is necessary, and in turn, failing to inquire about the patient's own knowledge or ideas. Often, our patients are very well aware of the risk of their health behavior. And while there are certainly many circumstances in which healthcare providers have new or relevant information, most of us err on the side of providing more information than is necessary. Sharing excess information can make patients feel invalidated. It can create passivity or create an imbalance in the relationship. An example would be explaining a long list of strategies for cutting down on drinking without first asking what ideas the patient has about cutting down. Later in the training, we will learn about strategies to encourage patients to state the information they know. That is a lot more powerful than hearing it from someone else, and can help them actively engage with that information in order to apply it to their own health behaviors. I'm wondering if you can think about an instance where maybe you experienced one of these previous roadblocks to communication, whether in your personal or professional lives. Right, now that we have talked about the barriers, let's talk about the facilitators. There are a number of strategies that build rapport and trust with patients that can facilitate therapeutic conversations and improve the chances that patients will change unhealthy behaviors. These are empathic listening and using reflections and summaries, highlighting patient choice, using affirmations, seeking collaboration, and the ask, tell, ask technique. Empathic listening involves seeking to understand what another person means by communicating it back to them in the form of a reflection or a summary. When we reflect or summarize what patients have said, we not only help to ensure accurate understanding, but we send our patients the message that we care about and accept them. Additionally, by serving as a sounding board for our patients, we can often help them to get unstuck and make progress in thinking about change. Reflections are statements that paraphrase what a patient has said, distill its meaning, connect it to something else the patient has said, or highlighting the underlying emotion or affect of what was said. Let's look at the example here. Patient: before I knew I was pregnant, I was drinking a lot. I'm not sure what to do. And the medical assistant's response: it sounds like you're a little worried and might want to talk to the provider to get some more information. The next strategy is highlighting patient choice. Emphasizing patient's choice can help empower them to act and increase their sense of confidence. Whether or not patients choose to engage in medical care with us or change their health behaviors when they leave our office is completely up to them. So again, let's look at the example. You know yourself best. What do you think would be the best choice for you? Affirmations are yet another facilitator. Affirmations can be effective in promoting a positive working relationship with patients, building patients' confidence in their ability to make healthy choices, and can be really useful in reinforcing healthy behaviors. Affirmations should be genuine and authentic. For example, you have a lot of great ideas about how to reduce your chances of having an unintended pregnancy. Seeking collaboration is sharing power on the direction or focus of the interaction. This could involve asking permission to address an agenda item, share information, or make a suggestion or other behaviors that highlight patient knowledge. An example is, what would be a helpful next step? Or, would it be all right if I ask you a few questions about sexual health? As we learned in our roadblocks to communication section, one-way exchange of information often fails to tap the expertise and knowledge of the patient. In many circumstances, the patient will already know the information that you were hoping to share. Information can have a more powerful impact on thinking when it is stated by the patient instead of by us. Additionally, by asking patients to talk with us about what they already know, we can identify potential gaps in their knowledge or misconceptions. We can also get a sense of their level of health literacy, which can help us gauge the way in which we share information going forward. In the ask, tell, ask technique, after asking patients what they already know, we can tell them information, if it's necessary, in a way that is tailored to their current knowledge. Lastly, we can ask a follow-up question that asks the patient to apply the information to their own thinking about change. Let's look at the example. The medical assistant asked, "What's your understanding of some of the potential health effects of drinking more than 3 drinks in a day?" The patient says, "Well, it might give you a hangover." The medical assistant: "Yes, it can lead to hangovers. It can also increase the chances a person might have an accident while drinking, like tripping and falling, or experience social consequences, such as saying or doing something you regret later." How does that impact your thinking about your own drinking? Let's think about some of those techniques that are on the superhighway that might help your communication with patients. Right? Remember that we want to use reflections and we want to summarize. Right? We want to highlight choice. We want to affirm. We might want to say something like, "You're the kind of person who really likes to be informed about your medical care." And we want to seek collaboration. For example, We talk with all of our female patients about alcohol use and contraception. Would it be all right if we continue? Okay, we have now completed section 3, and we are in the home stretch. But first, let's review. First, what are some common communication roadblocks? Unsolicited advice, persuasion, confrontation, getting ahead of patients, and one-way information. How does communication affect change? Well, ineffective communication can damage rapport, it can increase resistance to change, and it can diminish trust in the healthcare system. Whereas effective communication can build rapport, can motivate behavior change, and can facilitate gathering of accurate information. How can medical assistants communicate more effectively? By using the superhighways to communication, the things we just talked about, empathic listening, using reflections and summaries, highlighting patient choice, using affirmations, seeking collaboration, and using the ask, tell, ask technique. We are going to go ahead and close out the curriculum portion of the training by highlighting some take-home messages. First, alcohol affects multiple organ systems throughout pregnancy, particularly the baby's brain. FASDs is an umbrella term that describes the range of effects that can occur in an individual who was exposed to alcohol before birth. The term FASDs is not intended for use as a clinical diagnosis. The term fetal alcohol spectrum disorders, or FASDs, has emerged to address the need to describe the spectrum of disorders related to fetal alcohol exposure. The range of effects can include physical, mental, behavioral, learning disabilities, or a combination of these, with possible lifelong implications. Unlike people with FAS, or fetal alcohol syndrome, those with other prenatal alcohol-related conditions under the umbrella of FASDs do not show the identifying physical characteristics of FAS, and as a result, they often go undiagnosed. It is important to note that we are not saying a person who may become pregnant can never drink. But for questions regarding the critical periods of development and the question about when it is safe for someone who could become pregnant or is pregnant to consume alcohol, there are important considerations, including people don't usually know they are pregnant until approximately 4 to 6 weeks gestation, and 50% of pregnancies are unplanned. Most people do not know when they conceive, so all people who may become pregnant should be cognizant of their alcohol intake and aware of the problems associated with alcohol consumption. For people who are pregnant, there is no safe time for them to drink alcohol, no safe type of alcohol, and no known safe amount of alcohol that can be consumed during pregnancy. Conversely, it is never too late to discontinue drinking alcohol when pregnant. Remember universal screening. We want to screen all patients who may become pregnant. And lastly, just how we began, remember that language matters. As healthcare professionals, we want to avoid stigmatizing language. We want to use person-first language. We want to avoid gendered language. use superhighway communication techniques and avoid roadblocks. And remember, using thoughtful language can improve communication with patients and help prevent alcohol-exposed pregnancy. Thank you. I appreciate you joining me for this webinar. I hope you found it helpful. As a note, since this project does receive funding from the Centers for Disease Control and Prevention, I would like to say that the views expressed in written materials and by me, the speaker, do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. Thank you so much and enjoy the conference.